Welcome everybody to today's session. I'm Kevin Afra, I'm an infectious disease physician, and I also do antibiotic stewardship and infection control in my health authority in the Greater Vancouver area. Today's session is on antimicrobial stewardship, and we're going to discuss some of the harms and benefits of antibiotics and their treatments, as well as strategies that might be applicable predominantly in primary care. I don't have any disclosures to make for today. Our learning objectives for today's session, by the end of this, you'll be aware of the harms of antibiotics. You'll better appreciate which common infections are in primary care benefit from antibiotics and which don't. And you'll know the evidence-based recommendations for treatment duration for when to prescribe antibiotics. We'll start a little bit with the harms, and I think it's really important to recognize the harms of antibiotics when we're making decisions around prescribing. Harms can be quantified at a societal level, and it's been shown quite clearly in many nations that the amount of antibiotics we use correlates very closely with how much antibiotic resistance we see. And this was shown several decades ago with penicillins and resistant streptococcus pneumonia, and it's been shown repeatedly since then for a wide range of antibiotics and organisms. But the risk for antibiotic resistance isn't just at a societal level, it's also at an individual level. And I think this is one area where we can all do a little bit better to understand the harms and risks, because the societal level is quite remote from our patients in an individual patient encounter, and it's hard for us to incorporate into our clinical decision making. But at an individual level, we have seen most clearly in the hospital setting where we have excellent ability to collect the data, that every additional day of antibiotic exposure increases your risk of resistance to that particular antibiotic anywhere on the order of 2 to 10%. And so this is a significant risk for each additional day of antibiotics our patients are exposed to. When our patients do acquire antibiotic-resistant organisms, that resistance can stick around for quite a long time. And this has been shown in a wide range of studies in both the respiratory tract infections and urinary tract infections, that the patients who acquire antibiotic resistance can have that resistance last for even up to 12 months, if not longer, to that particular antibiotic, regardless of what class it was in terms of which antibiotic was prescribed. Those harms are sometimes a bit difficult to incorporate still into our clinical practice. So I also want to highlight some more pressing harms that your patients really can be impacted on, not just antibiotic resistance, and that is predominantly C. difficile. C. difficile, as we know, is a complication of antibiotic exposure, but we may not recognize that the harms of C. difficile can be adjudicated even at a daily basis. So every additional day of antibiotics that our patients are exposed to increases their risk of harm from C. difficile. Furthermore, we have seen in clinical literature that over 7 days is really where a tipping point seems to occur, where beyond 7 days of antibiotic exposure, there's a significant increase in the risk of acquiring C. difficile infection. And so we do want to worry about any treatment courses that go beyond 7 days, even though the first few days are also an increased risk from not getting an antibiotic at all. We've also seen the harms of antibiotics for other side effects and adverse events. This was shown quite clearly in a large retrospective study of patients who had pneumonia and discharged from hospital in Michigan. They found that almost 2/3 of these patients had unnecessarily prolonged antibiotics when they were discharged from hospital, and that 93% of that unnecessary duration happened at the time of hospital discharge. Only a small proportion happened while they're still in the hospital. Now, you may say as primary care providers, this is not really our issue. This is the hospital physician's issue. But I think what we can learn from these studies is that a lot of the harms translate irrespective of what syndrome we're treating and where the patient is being treated. And what they found in this particular study was that each additional day of antibiotics the patients were exposed to beyond what they needed to receive translated to a 5% increased risk of adverse events for that patient. And so we can extrapolate from this in many ways that all the extra harm that we provide in terms of excessive duration has a clear number, and that's 5% per day. So when we recognize better the harms of antibiotic prescribing, we do need to use some strategies to try to reduce the prescribing of antibiotics, especially when they're not needed. I kind of see it in two particular buckets. One bucket is to reduce the prescribing of antibiotics where they provide little or no benefit. I think that would be ideal, and that it doesn't expose patients to any amount of antibiotics and the harms that come from that, including antibiotic resistance. The other is if you do need to prescribe an antibiotic, and there are many syndromes and situations where we do, is to use evidence-based durations of therapy. And so we're providing as little harm as we can in the setting of trying to cure an infection. So let's start with the first strategy, and that is reducing the prescribing of antimicrobials. A good place to start is to understand the underlying likelihood of a bacterial infection. And I'm going to predominantly speak about syndromes that are seen in primary care, and most of those that lead to antibiotic prescribing are respiratory tract in nature. So let's start with pharyngitis. Pharyngitis is about 20 to 30% bacterial in children and about 5 to 15% in adults. So it's less likely to be bacterial in adults than it is in children. The most common pathogen, of course, that we care about is group A streptococcus, but there are other bacterial pathogens that can cause pharyngitis as well. In terms of other respiratory tract infections, sinusitis is very rare to be bacterial, and I think this is a misunderstanding often, in that most sinusitis is viral in nature, and only around 2 to 10% of sinusitis is bacterial. And the likelihood of developing bacterial sinusitis is essentially 0% in the first 7 days. It's only in those who have more persistent or prolonged symptoms beyond 7 days where bacterial sinusitis is even a remote possibility. Now we can shift to the other side of the spectrum, acute otitis media. And this is one where bacterial pathogens are found in almost 80% of cases. And so bacterial are very common. That doesn't necessarily mean they all need treatment. We're going to come to that later. But this is probably on the other end of the spectrum in respiratory tract infections of where bacteria are predominant and where they are not. As we go down the respiratory tract into bronchitis and acute bronchitis, only around 5 to 15% of those cases are associated with the bacterial pathogen. And so it's the predominantly still viral in nature. And lastly, I just want to mention community-acquired pneumonia. I think historically we had always thought that community-acquired pneumonia requires antibiotics, and that's because we often thought that these were bacterial in nature. And I think in the more recent years, we've particularly better understood the role of viral infections in community-acquired pneumonia. A large US study that was done by the CDC did quite thorough investigations for patients presenting to hospital with community-acquired pneumonia, and despite their extensive investigations, could only find the bacterial pathogen in about 14% of patients, and this was before COVID. And since then, that distribution has skewed even more towards the viral side of the spectrum. So if we have a better understanding of what syndromes are bacterial and how likely they are to be bacterial versus viral, we can better understand when and where antibiotics are actually likely to provide benefit or help. And ultimately, we want to have a risk-benefit ratio where the benefits outweigh the harms of prescribing. And those are scenarios where we want to try to identify so that we know where an antibiotic is likely to help and where it's not likely to help. So syndromes that have a low likelihood of being bacterial generally are going to have the least benefit from antibiotics. That makes sense. And even some syndromes where bacteria are more common, and we're going to come back to something like acute otitis media later, they can often be self-limited. So just because something is bacterial doesn't mean it's going to remain unless it receives an antibiotic to cure it. So let's start with some of these clinical syndromes that we mentioned. So pharyngitis, historically, if we go back in the medical literature and medical practice, the goal was to eradicate group A streptococcus from the throat in order to prevent particularly rheumatic fever, as well as to some extent the local complications that can occur with streptococcal pharyngitis. Now, rheumatic fever is exceedingly rare in places like Canada and the United States, although I'll highlight, depending on where you practice, there are still significant disparities in some First Nations communities. Antibiotics, in terms of their benefits, they do reduce some of the complications locally, although the amounts in terms of absolute values are quite low to start with. So complications like acute otitis media or peritonsillar abscess only occur in about 2% of patients, and this is reduced to about 0.5% in those who receive an antibiotic. Now, it's important to also recognize that these complications of pharyngitis are delayed. They can occur over a span of 2 to 8 weeks. They don't occur immediately or in the first few days of their clinical illness. In terms of other benefits from antibiotics, predominantly symptomatically, antibiotics do provide a symptomatic benefit in terms of shortening the duration of illness, but that shortened duration of illness is only about an average of 16 hours over the span of 7 days. So you're not even getting a day less of clinical symptoms when you're prescribing an antibiotic in terms of its benefits. So how can we work through some of this and understand the rationale for when and where antibiotics are needed? So first of all, we've now understood that pharyngitis, for the most part, is not group A streptococcus. In fact, 70 to 80% of presentations of pharyngitis are not group A streptococcus. We also better understand the complications of group A streptococcal pharyngitis are rare and they're often delayed. They're not going to happen in the first few days of illness. And we also better understand that the symptomatic benefit of antibiotics is marginal, somewhere on the order of half a day or so. And so that leads into where the clinical guidance in North America comes from in recommending microbiologic diagnosis before giving antibiotics. In order to avoid unnecessary testing of patients who are unlikely to have group A streptococcus, most North American guidelines also incorporate clinical decision scoring system. In Canada, our Choosing Wisely campaign recommends a modified Centaur score. For those of you who aren't aware of the modified Centaur score, it's very similar to the Centaur score with some extra modifications to just be a little bit more sensitive and specific. The modified Centaur or M Centaur includes age over 3, in that patients who present under the age of 3 can have a bit of a different clinical presentation with group A streptococcal pharyngitis, so the classic Centaur score may not be as applicable. You do get a point for each of the following criteria as well, including not having a cough, having tonsillar exudates or swelling, having anterior cervical adenopathy, having a temperature of over 38 degrees Celsius, having an age under 15 years of age, as well. You get a subtraction of a point if you're over the age of 45, since they're very unlikely to have group A streptococcal pharyngitis. So only in patients who have a modified Centaur score of 2 or greater, greater than 2, in those patients, some sort of microbiologic diagnosis should be done, whether it's a throat swab for culture, or if you have access to it, a rapid antigen test. And in those patients where you've made a confirmed diagnosis of group A streptococcus, then those are the ones where antibiotics can be prescribed. In the vast majority of patients, they don't require any antibiotics, and many of them don't even require any microbiologic testing because the likelihood of group A streptococcal disease is low. Next, we can move on to sinusitis. As we mentioned before, sinusitis is almost always viral. The complications of acute bacterial sinusitis are exceedingly rare. So on the order of 1 in 10,000 to 1 in 30,000 cases develop a more complicated picture, such as spread of the infection to intracranial tissues or meningitis, or mastoiditis, which are some of the more worrisome complications. So they are very, very rare, which is reassuring. Also, the majority of patients improve irrespective of antibiotics. And so even those who do have bacterial sinusitis, many of them will have a self-limited illness, and their disease course will improve irrespective of the antibiotics they receive. Antibiotics may shorten the duration of their symptoms. Similar to pharyngitis, you do get a little bit of benefit, although it's not that big clinically, to be honest. And when we look at the benefits of antibiotics compared to the harms, the number needed to treat with antibiotics is about 8, whereas the number needed to harm in terms of adverse events is also 8. And so the number of patients who will receive a benefit from an antibiotic is about equal to the number that will be harmed from an antibiotic when we prescribe for acute sinusitis. This has led our North American guidelines to try to tease apart the patients that are most likely to benefit from an antibiotic, and those are the ones with bacterial disease. Again, this is mostly syndromic. We don't have very good microbiologic testing for sinusitis. So those who have a syndromic diagnosis of bacterial sinusitis, and particularly those who have more severe symptoms, are the ones that are probably most likely to benefit. In terms of our algorithm for this, we're looking for patients who predominantly have symptoms for more than 7 days. As we mentioned before, if you have symptoms for less than 7 days, it's very, very unlikely that you have a bacterial pathogen. So those who have symptoms for more than 7 days, there's an acronym you can remember, PODS, P-O-D-S, so facial pain, pressure, or fullness, nasal obstruction, nasal purulence or discolored postnasal discharge, and hyposmia or anosmia or smell issues. Patients who have symptoms for more than 7 days and have at least 2 of these major symptoms, including one of them being nasal obstruction or nasal purulence or discolored postnasal discharge, are more likely to have a syndromic diagnosis of acute bacterial rhinosinusitis. And of those patients, if they have more severe illness, they may benefit from an antibiotic. Even if they have acute bacterial rhinosinusitis and they only have mild or moderate symptoms, most of those patients don't need an antibiotic. They can be managed with counseling, with intranasal corticosteroids, or saline rinsing as well. There are a few other considerations for bacterial rhinosinusitis, and that is to consider the possibility of a biphasic illness. So those are patients who have some sort of rhinosinusitis. It gets better, and then it gets worse again after about 5 or 7 days. They're more likely to have bacteria present. Those who have symptoms for more than 7 days, as we mentioned, is another criteria to be considerate of. And then lastly, those patients who have severe amounts of purulence and high fever for 3 or 4 days or longer. These are also considerations for the patients that might have bacterial rhinosinusitis. Moving on to acute otitis media. This is an interesting one where viruses and bacteria are often both present in most cases. Predominantly, the viruses may initiate the infection, and then the bacteria somewhat continue it as well. Common complications that we watch out for acute otitis media are things like recurrence of disease, hearing loss, which in the vast majority of cases is transient or temporary, as well as perforated eardrums. When we look at the clinical literature in terms of benefit of antibiotics, they do make a minimal difference in terms of some of these common complications, although the amount of clinical benefit we get is actually less than many think. In terms of serious complications for acute otitis media, whether that's mastoiditis or meningitis, fortunately, that's quite rare. You would have to treat 5,000 patients to prevent one case of mastoiditis, meningitis, or other serious complications. So you can see how rare that is. Antibiotics, what we do know now from our clinical evidence is that it's most beneficial to prescribe antibiotics in those who have the most stringently diagnosed acute otitis media. So how do we make this stringent diagnosis? That's what's reflected in the clinical guidelines we have in Choosing Wisely campaign in Canada and in many similar places, and that we don't want to be prescribing antibiotics for patients unless they have a high likelihood of bacterial infection, and more so a bacterial infection that's going to respond well to antibiotics. So who are these patients? They're kind of in one of two categories. First are the group of patients who have a perforated tympanic membrane with purulent discharge. They're very likely to have bacterial infection, and they're very likely to benefit from antibiotics. The second group of patients are those who have a bulging tympanic membrane with any of the three following criteria. So that's fever of 39 Celsius or higher, moderate or severe illness, or significant symptoms lasting for at least 48 hours. So that's the second group of patients that are more likely to have bacterial disease and most likely to benefit from antibiotics when we look at the clinical trials for acute otitis media. Moving on to acute bronchitis, as we mentioned before, bacteria are unlikely in this clinical syndrome, looking at around 5 to 15% of cases at most have a bacteria present. I think what's most important for acute bronchitis is to just be aware of the natural history of this condition, in that only half of patients are lucky enough to have symptoms that resolve within 3 weeks. The other half of patients have symptoms that go beyond that, and about a quarter of patients have symptoms that go beyond 1 month. And so I think it's really important in these scenarios to counsel our patients what to expect in terms of how long these symptoms can last until they resolve. Acute bronchitis, we do know, is self-limited, even those who have bacterial etiology. We also know in the literature that antibiotics don't prevent complications like acute otitis media or pneumonia. They don't do anything to prevent those. And in terms of symptomatic improvement, again, we see the same minimal symptomatic improvement with antibiotics in terms of resolution or improvement of cough, about half a day better with antibiotics compared to no antibiotics. And so recommendations in Canada are to not prescribe an antibiotic for bronchitis. And I think this is quite similar in many other jurisdictions as well. Lastly, in terms of clinical syndromes, before we move on to some of the strategies, is to just briefly mention acute simple cystitis. And I think I wanted mostly mention this because it's underappreciated how self-limited this condition can be. Now, by definition, acute simple cystitis is 100% bacterial if you do cultures and you look for the appropriate number of pathogens in the urinary sample. Now, that's not always done or necessary in primary care, but in terms of textbook definition, you're predominantly dealing with the bacterial infection. What's important to recognize is that about a third of patients self-resolve their illness without any antibiotics at all. What antibiotics do is improve the rate of cure from about a third up to about 80 to 90%, so significant improvement in cure rates. But it's not like simple cystitis is uncurable without antibiotics, so many patients do get better on their own. The other thing antibiotics do is reduce the risk of relapse compared to placebo. Patients who get an antibiotic have about a 15% chance of relapsing UTI, whereas those who don't get an antibiotic have about a 40% chance. And this has been shown in many clinical trials that have compared antibiotics to either placebo or anti-inflammatory medications like ibuprofen. Something that everyone is concerned about is more complicated secondary sequelae of cystitis, things like pyelonephritis. What we know, fortunately, is pyelonephritis is actually quite rare. Only about 1% of patients with cystitis develop pyelonephritis. And because it's so rare, antibiotics provide only minimal benefit, if any, in terms of preventing pyelonephritis as a secondary complication of simple cystitis. And so we've talked a little bit about the likelihood of bacterial infection. We've gone over some of the expected benefits from antibiotics in various syndromes, many of which have very limited or no benefit, some of which have more benefit. We've also talked about the harms of these antibiotics. I think if we incorporate these better into our clinical practice, that can help us in terms of making better decisions around clinical diagnosis and the role of therapy. It can also help us better educate our patients and counsel them, especially for these self-limited infectious syndromes. But sometimes that's not enough. Sometimes we may be dealing with our own clinical uncertainty or therapeutic uncertainty about whether a particular antibiotic might provide our individual patient benefit. Sometimes we have issues with patient follow-up, and we may not feel comfortable that the patient can adequately follow up with us if something isn't going right. And sometimes we have challenging patient encounters where we just need other strategies to not necessarily prescribe an antibiotic, but to perhaps do it a different way. And that is the role of delayed prescriptions. Now, what are delayed prescriptions as a strategy? It's prescribing an antibiotic only if the patient's symptoms worsen or fail to improve. Typically in the clinical literature, this has been at least a 48-hour lag time between when someone presents to you in your practice and when the antibiotic is prescribed. It's in that intervening time frame that many patients realize they're getting better and don't require the antibiotic. Practically, how this can be done is the prescription can be left with your reception desk if the patient calls back after whatever time frame that you've counseled your patient upon, or you can give the patient the prescription with counseling saying don't fill it for another few days and only in these certain scenarios, and we'll go over that in more detail. Now, this strategy is quite widely used and referenced in other jurisdictions, particularly the United Kingdom has incorporated this into their NHS guidelines for a lot of common respiratory tract infections and UTI. It's been primarily studied in those scenarios as well. But I find that it's lesser used in the North American treatment context, and I think it's underutilized as a strategy that we can use to avoid prescribing antibiotics. Delayed prescribing requires really good patient education and counseling. It also is important to let your patients know that they may feel a little bit worse in the first few days before they start to feel better. The delay in which you provide in terms of natural history and counseling before filling the prescription can also be tailored to the clinical syndrome in which you're dealing with. So what's been used in the literature predominantly has been for ear infections, a 3-day delay, for pharyngitis, a 5-day delay, and things like acute rhinosinusitis, 10-day delay. And we talked about earlier how and where each of these delays makes the most sense clinically and biologically. Now, some of the clinical studies have looked at things like common cold, as well as acute cough and bronchitis, and they've used the delay of 10 days. I would be cautious in implementing this in your practice because this may actually be sending the wrong message that there potentially is a role for antibiotics in things like common cold or acute cough or bronchitis. And that is not the kind of education we want to be providing to our patients because it may just lead them to present to you in the future for the same clinical scenario and syndrome where you still feel antibiotics are not necessary. So I would predominantly use this as a tool in things like ear infections, pharyngitis, and acute rhinosinusitis. Now, delayed prescriptions have been studied quite extensively. There was a recent meta-analysis of 13 randomized controlled trials with at least 55,000 patients involved in that meta-analysis, where they looked at immediate versus delayed prescribing of antibiotics for respiratory tract infections. What they found is there's no difference in symptom severity at days 2 to 4, whether you did an immediate prescription or you gave the patient a delayed prescription. There was a slightly longer time to full symptom resolution with a delayed strategy, but it was only about half a day difference between the two. So it was not that meaningful clinically. There's no difference in terms of reconsultation rates of patients coming back to their care provider for repeat assessments. There's no difference in hospital admission or mortality, and there's no difference in patient satisfaction scores. This was also reviewed by the Cochrane Group in a Cochrane review published just last year, where they looked at not just immediate prescribing and delayed prescribing, but also compared it to no prescribing at all. And I think this is the most telling in that sometimes we worry if we give a delayed prescription, most of the patients are just going to go and fill it anyways, but that's not actually what they found in these clinical studies. And in fact, only about a third of patients who are given a delayed prescription ever fill the prescription and use the antibiotic. So there's a significant reduction in antibiotic use for these patients. Meanwhile, patients are quite satisfied. Patient satisfaction is around 90%, whether you give them an immediate prescription or delayed prescription, and both of those strategies are better than no prescription at all in terms of patient satisfaction, which is important, although not necessarily the whole picture. In terms of clinical outcomes, the modest benefit was best seen in sore throat and acute otitis media, and we've talked about before earlier in this session where and why antibiotics may be beneficial in both of those clinical scenarios. As expected, things like cough and common cold, there is no clinical outcomes difference in terms of symptom resolution or otherwise. And importantly, there is no signal of harm in terms of adverse events being different between any of these three strategies that were under investigation. So I do think delayed prescriptions are a useful tool to have in our toolkit. We can reduce antibiotic use by our patients by about 70% with this strategy. Our patients remain quite satisfied. A lot of that satisfaction in the clinical studies comes from the education and counseling the patients receive. Just because they come to your office doesn't mean they want a prescription for an antibiotic. They often are looking for answers and counseling as to what to expect. And if they know to expect that they're going to be getting better, but it might take a week or two, that's often enough for many patients. And I'm also finding in general that our health literacy in many of our patient populations is improving, and many patients are not coming expecting an antibiotic, and they're better understanding the differences between things like a bacterial infection and a viral infection. Also important with a delayed prescription is that the outcomes clinically are nearly identical, whether you give an immediate prescription or a delayed prescription. So that at least does give us some peace of mind in terms of our clinical decision making and our prescribing. So those are some strategies we can use to reduce the prescribing of antibiotics in the first place. And as we come towards the last section of today's talk, we're just going to cover some of the evidence-based durations of therapy, because as we mentioned, there are times you do need to prescribe an antibiotic, and there's a number of clinical scenarios where we haven't talked about yet, where antibiotics are indicated, but we often are treating much longer than we need to. And by reducing that duration of therapy, we can reduce the risk of harm and antibiotic resistance. So if we start again with pharyngitis, unfortunately, we haven't done a great job in reducing the duration of therapy for this one. The recommended duration is still 10 days, but the reason why I think is important to recognize, and that is not because 10 days gives us any better clinical cure. We've had many trials that have looked at 5 days or 7 days, and the rates of clinical cure are nearly identical. What 10 days does provide is better microbiological eradication, so better ability to get rid of group A strep from the back of the throat. And that's the bigger concern in terms of risk of rheumatic fever and some of the other sequelae of group A streptococcal infection, is that persistent colonization in the throat with whatever pathogenic strain of group A strep an individual has been colonized with. And so the benefit with antibiotics, about 90% of patients will eradicate group A strep from their throat. With 10 days in clinical trials that have tried 5 days of therapy, that drops to about 80%. So it is a significant difference. Moving on to sinusitis, the recommended duration of therapy for this is 5 to 7 days. It was important to realize that some patients may require clinical reassessment at day 7. And this is primarily to provide counseling and education, as again, we do know that sinusitis can have quite a protracted treatment duration or natural history before it gets better. For acute otitis media, there is some evidence for shorter durations of therapy, particularly in those who are 2 years or older, where 5 days is the recommendation. In patients who are under the age of 2, it's still a 10-day recommendation for therapy. And in patients who have a perforated tympanic membrane or have recurrent acute otitis media, that also still remains a 10-day duration of therapy. But a large proportion of patients can be treated with 5 days of therapy, which is a significant reduction from historical norms. Moving on to the lower respiratory tract with community-acquired pneumonia, our North American guidelines in 2019 recommended 5 days of therapy for community-acquired pneumonia. Since then, we've now had better randomized controlled trials of even shorter durations of therapy. Most recently, a trial was published in 2021 for hospitalized community-acquired pneumonia, where they were looking at 3 versus 8 days of therapy, and they found equivalent clinical cure rates, equivalent length of stay, and equivalent mortality between the two strategies. And so we do now know from these RCTs that we can go even shorter than 5 days. And the vast majority of particularly outpatient pneumonia, which is on the less severe side of the clinical spectrum, can be treated successfully with only 3 days of antibiotics, which is a major change from what we are used to historically. Up to 5 days may still be needed in some patients if they have more protracted fevers and are more slow to resolve. One clinical pearl I'll leave you with is that outpatient community-acquired pneumonia should never need more than 7 days of antibiotics. If you find yourself prescribing a repeat course of antibiotics or longer than 7 days, you need to ask yourself if something is wrong. Has the patient developed a complication of the pneumonia that's gone undiagnosed? Or do they have other reasons for their clinical symptoms and illness that is no longer a bacterial pneumonia in nature? As we move on to some of the other clinical syndromes, there is quite a bit of new literature in complicated UTI. We know for cystitis that short courses of therapy are well established for simple cystitis in women, as short as 1 day of therapy with something like fosfomycin. Most treatments are on the order of 3 to 5 days, depending on the agent used. But we also have much better evidence for things like pyelonephritis now. Over the last few years, we've had a trio of randomized controlled trials published on gram-negative bacteremia, most of these from pyelonephritis. And what we now know is 7 days is the standard of therapy for acute pyelonephritis, including patients who develop bacteremia. So we are quite comfortable with this treatment duration in patients with acute pyelonephritis, which is, again, a major change from historically where we would typically do 10 or even 14 days of therapy. Male UTI remains a little bit more challenging. And so we do have some recent literature, and afebrile men with UTI or simple cystitis, 7 days has been shown to be equally effective as 14 days. So we have been able to reduce the treatment duration for this population of simple cystitis in men. But we do need to be cautious. In febrile men with UTI, a lot of them will have some form of complicated UTI, whether it's pyelonephritis or more concerningly prostatitis. So my personal practice, any febrile male UTI, I will always clinically assess them for prostatitis. And how I do that is I look for recurrence of the same uropathogen in multiple repeated cultures. Say they've had cultures in the past with the same E. coli and they're growing the same E. coli again. I would be much more concerned they might have a prostatitis. I'll assess them for any perineal pain. And I always do a DRE in febrile male UTI to see if they have a tender prostate, which is highly diagnostic of acute bacterial prostatitis. Patients who do have any evidence of prostatitis will need at least 14 days of antibiotics, and most of them will need longer, on the order of 1 to 1.5 months of therapy. And as we come to a close, I just want to briefly mention cellulitis as well. Our recommended duration of therapy now for cellulitis is 5 to 7 days based on clinical trials. But there are some important clinical pearls to take away from cellulitis. And that is something I often see as an ID specialist, is that cellulitis often looks worse in the first 1 or 2 days of therapy before it gets better. And that is because of the rapid inflammatory response that occurs as bacteria are dying from the antibiotics that we're prescribing. That causes a lot of inflammation. The recommendation is to still continue our guideline concordant therapy, but also to assess for possible red flags. And those are things like severe disproportionate pain or progressive sepsis. Either of these would be more concerning, and we would want to be thoroughly assessing our patient for the possibility of a necrotizing soft tissue infection. This is quite uncommon still, and particularly in the outpatient setting. And so most of these patients, we need to just counsel them that there could be a little bit of worsening in the first few days, what to watch out for, and contact us again if these things happen. But most of the time, 5 or 7 days will be more than sufficient to cure their infection. I think an important recent trial that was published is very helpful in our patient counseling and our assessment, is why sometimes the limb can remain quite red and swollen. And so this particular trial looked at a recent randomized study of therapy for cellulitis. So these are patients who all had good, appropriate treatment for the cellulitis. And they looked at the natural history of what happened up until day 10. By day 10, a third of patients still had a 2 centimeter or greater difference in circumference between the affected limb and the unaffected limb. A third of patients still had a 1 degree Celsius difference in temperature between the limbs. So the legs still felt warm, for example, compared to the other side. And this is at day 10, mind you. So after the antibiotics had already been done for a few days. Half of patients had a reduction in the area of redness, but half of them, they still had quite significant amount of redness, and half of patients had residual pain. And I think this comes to an important aspect of any antibiotics we prescribe, is that infections are both infectious, they have a bacterial pathogen, but they're also inflammatory. And so while antibiotics can cure the infection, the underlying inflammatory process that develops during any infection has its own natural history, and it just takes time to improve, whether it's cellulitis or pharyngitis or many other clinical syndromes. So in summary, every day of antibiotics exposes our patients to potential harm. We've quantified those earlier in the session. Many common infectious syndromes are viral, and even the bacterial ones are often self-limited. It's important that we understand all of these so we can better educate ourselves, make better clinical decisions, but also counsel and educate our patients. Another useful strategy that we've talked about is delayed prescriptions, which can be used in select circumstances, and you have those at your disposal. And ultimately, if we do prescribe an antibiotic, we should use the shortest course necessary to cure the patient, and no more than that, because anything more than that just exposes our patients to harm without any of the potential benefits. So with that, we can bring the session to a close. Thank you very much for listening.